The guidelines have changed a lot through the years as to how we should have a conversation with somebody. What are the issues that an individual needs to know in order to have an informed conversation of what is your risk for heart attack, stroke, and diabetes, which is collectively what cardiometabolic risk is speaking about. The guidelines started by having just major risk factors identified, and that would be your age, your gender, your blood pressure, your total cholesterol, your good cholesterol, smoking status, diabetes. And depending on what your answers were to that, you got put into a category of low risk, high risk, or something in the middle. The problem was that missed a lot. And a lot of the factors that we now appreciate that help us have a better individual conversation are called risk enhancing factors. And those risk enhancing factors include a variety of things. Risk enhancing factors include insulin resistance. Risk enhancing factors include metabolic syndrome, chronic kidney disease. It includes certain clinical categories that people may have, such as high inflammation, due to something like rheumatoid arthritis or just a biomarker of high inflammation. It includes a better description of your risk, more than just what's your cholesterol, but what's going on with the particles that cause blockage that carry your cholesterol. Is your ApoB high? Do you have a very high type of ApoB particle called lipoprotein a? All of these are additional things that we need to know. In the 2013 timeframe, the guidelines began to lean into non-invasive imaging. We can now look at vessels without having to go to the cath lab and say, is there a blockage that we can identify that's developing? And if you have evidence of a blockage, either by a coronary artery calcium score or a CTA or B-mode ultrasound of the carotid arteries, if we can find plaque in your vessels, then that's another major risk enhancing factor. And it basically changes the conversation. Do you already have the thing we're trying to turn off that has evidence of having turned on? So you can see that what should be going on with an individual patient is a more complex conversation than just what's your risk score. If we put your risk factors into a calculator and the calculator spits out a 10-year risk or a 30-year risk, that's a generalization. And the individual that is being categorized may be over-categorized. We may have somebody who is told they're at high lifetime risk, but that risk could be overestimated. We could tell them they have a low 10-year risk, but that risk could be underestimated. And then there are factors in cardiometabolic risk, which we know just by having them put you definitively at high risk. For example, metabolic syndrome. If you have metabolic syndrome due to how much your waist size is, what your blood pressure is, what your good cholesterol is, what your triglycerides are, what your glucose is, we know that people with metabolic syndrome are at high lifetime risk. We know that if you have a very high ApoB, or the number of atherogenic particles, that's a risk enhancing factor as well. So these are all things the clinician is asked to do on the fly, right? You see somebody, you walk into the room, you have all of these various factors that you're supposed to, on the fly, have a conversation about. And that's hard. That's a really hard thing to do.